Hello everyone and welcome to our module on shunts. So in this video we're going to talk about shunts, and what I mean by shunts is an abnormal communication between one of the structures in the right side of the heart and one of the structures in the left side of the heart. So for example, if there's a defect in the wall between the right atrium and the left atrium, then blood could move back and forth between the two structures. That's called an atrial septal defect, which we'll talk about in this video. An abnormal communication between the right ventricle and the left ventricle is called a ventricular septal defect. And we'll also talk about a patent ductus arteriosus, which is a persistent connection between the pulmonary artery, which is where blood goes after it leaves the right ventricle, and the aorta, which is where blood goes after it leaves the left ventricle. Before we talk about specific types of shunts, one thing to be aware of is that in general, left-sided pressures in the body are much higher than right-sided pressures. For example, a normal left atrial pressure is about 10 millimeters of mercury compared to about 6 for the right atrium. In the left ventricle, a normal pressure is 120/10 compared to 24/6 or so for the right ventricle. And the pressure in the aorta, as you may know if you've ever measured a blood pressure, normal is about 120/80 compared to a normal pulmonary artery pressure of about 24/12. So I don't think you need to memorize all these numbers, but you do need to appreciate that because the left-sided pressures are generally higher than the right-sided pressures, when there's a left-to-right connection, there should be left-to-right flow. So for example, if there's a ventricular septal defect, under normal conditions, you will have flow from the left ventricle to the right ventricle. That's because pressures are higher in the left ventricle and blood always moves from high pressure to low pressure. If there's an atrial septal defect, the normal way for blood to move is from the left side to the right side. And finally, if there's a patent ductus arteriosus, which we'll talk about later, blood normally flows from the aorta to the left pulmonary artery. So what this means is at the time of birth in a baby born with a shunt, there should be left to right flow through the shunt. This means blood will move from left-sided heart structures to right-sided heart structures, and the major problem is going to be volume overload of the right heart. We'll talk about this more later in this video, but the problem in babies born with very large shunts is usually that their right heart is overloaded and they develop signs and symptoms of right heart failure, things like elevated neck veins and lower extremity edema. Importantly, though, blood flow to the lungs is not impaired because we don't have shunting going from the right side to the left side bypassing the lungs. That doesn't occur. The shunt is moving blood in the other direction. So babies born with shunts should not have cyanosis present, and this is a basic super high-yield fact to know for your board exams. If they describe to you a baby that is blue and cyanotic, that baby probably does not have one of the shunts we're going to be talking about in this video. That baby probably has one of the more complicated congenital heart defects that I talk about in the video on cyanotic congenital heart disease. Now, if a baby's born with a significant shunt and it goes untreated for years, this almost never happens in the modern era, but eventually the pulmonary vessels become stiff and thick from excess blood moving through them. Also, the right ventricle begins to hypertrophy, and eventually right-sided pressures start to rise, and they can rise so much that the shunt can reverse and now start going right to left. Now, when this happens, blood is bypassing the lungs, so the child will become cyanotic. And this is called Eisenmenger syndrome when shunts reverse like this, and I'll talk about this later in this video. So it's sometimes said that shunts cause blue kids, not blue babies, and what they mean is there shouldn't be cyanosis at the time of birth. The only way a shunt's going to give you cyanosis is if you leave it untreated for years and years, and the child grows up and eventually the shunt reverses. Okay, now let's talk about specific types of shunts, and we'll begin by talking about ventricular septal defects or VSDs. And I'm starting with VSDs because these are the most common congenital anomaly, and they represent an abnormal communication between the left ventricle and the right ventricle. And classically, the murmur they cause is a harsh holosystolic murmur heard best at the tricuspid area, which is at the left lower sternal border. Basically, when you have blood moving from the left side, the left ventricle, over to the right ventricle through a small hole, that creates a murmur that you're going to hear during systole, because systole is when the left ventricle is contracting and it's pushing blood through that hole, making a systolic murmur. Classically, it's very harsh or very loud. There are many ways that VSDs are characterized. One of the most important ones to know for the Step 1 exam is by size, and I'll talk about this in a minute, but they're also characterized based on their location and based on whether or not they occur alone or with associated other defects in other parts of the heart. So the size of the VSD is very important in babies born with one of these shunts. If the VSD is small, that means there's a tiny hole in the septum between the left ventricle and the right ventricle. And it's very hard to push blood through tiny holes. So it's said that the small size of the VSD resists flow across the defect. And so sometimes small VSDs are called restrictive VSDs for this reason. When the hole is tiny, there's lots of turbulence as blood moves through the hole, so it can create a very loud murmur, and that's why VSDs classically cause a harsh or loud murmur, and it's because of all the turbulence if the VSD is small. The good news, though, is that when the VSD is small, even though it may create a very loud heart murmur, it's a small shunt. There's a small volume of blood flowing across the defect. So these are often asymptomatic, and often they're simply left alone and they will close on their own as the child gets older. On the other hand, large VSDs have a large hole between the left and right ventricle. These are sometimes called non-restrictive defects. In this case, there can be significant shunting, and these often have to be closed surgically. Interestingly, however, the larger VSDs sometimes have a very quiet murmur or no murmur at all, and that's because there isn't as much turbulence when the defect is much larger. Okay, now let's talk about atrial septal defects. So these are holes in the wall between the left atrium, shown here in my cartoon, and the right atrium here. They allow blood to go back and forth, and as we talked about, usually at the time of birth, blood flows from left to right. The major consequence of blood moving from the left atrium into the right atrium is that you add volume to the right side of the heart. This does a couple of things that create the abnormal heart sounds associated with ASDs. First of all, when there's more blood flowing through the right side of the heart, the closure of the pulmonic valve will be delayed, and this will cause a wide fixed splitting of the second heart sound. And I talk about how this occurs in the video on heart sounds in more detail. Also, because you have more volume on the right side of the heart, there's more flow across the pulmonic valve and the tricuspid valve, and this can generate a systolic ejection murmur. So in a board question, the findings you should expect if they're describing a baby with an ASD is a wide fixed split S2 and a systolic ejection murmur. You also can sometimes hear a mid-diastolic murmur from more flow across the tricuspid valve, although this is uncommon. But I put this here because you might see it in a board question if some tricky question writer decided to throw it in there. But just remember, when you see the wide fixed splitting of the S2 and the systolic ejection murmur, they're talking about an ASD. So one of the consequences of an ASD is oxygenated blood over here in the left atrium, blood that is just drained from the lungs, is going to cross over into the right atrium. And this is going to increase the oxygen saturation in blood samples from the right atrium, the right ventricle, and the pulmonary artery. And we can detect this in the catheterization lab in a baby with an ASD or even in an adult with an ASD by doing what's known as a shunt run. So you take a series of blood samples from different locations and you see when the oxygen level steps up because of the defect. So for example, in a child with an ASD, you could see an SVC, superior vena cava, saturation of 65%, and the same thing in the IVC. These are normal levels for oxygen saturation in venous blood. But then when you move to the right atrium, suddenly the oxygen level climbs up to 75% and it stays that high going forward. This is called a step up, and this is telling you that there's some abnormal communication allowing oxygenated blood into the right atrium, and the only thing that does that is an ASD. If there were a VSD, the step up would occur at the RV level, not at the RA level. And finally, if there were patent ductus arteriosus, the step up would occur at the site of the pulmonary artery. But the important thing to know here is that through this shunt run, you can detect where the defect is occurring. And it's high yield to understand this for your boards. They do like to sometimes show you these oxygen saturation numbers and see if you can figure out where the shunt must be. There are a number of subtypes of atrial septal defects, and the most common subtype is the secundum type. This is where the defect or the hole in the wall between the left and right atrium is at the site of the foramen ovale and the ostium secundum. So if you look at this cartoon on the screen here, I discussed this in detail in the video on cardiac embryology, but it depicts how the wall forms between the left atrium here and the right atrium here. And for that wall to form normally, two structures have to develop: the septum secundum, which is shown in red, and the septum primum, shown in blue. The septum secundum has to come down like this, and the septum primum has to persist up high enough here so that the two structures can seal. So the way you get a secundum type ASD is either the septum secundum doesn't grow down enough like this, or the septum primum doesn't grow high enough like this. This can happen if there's poor growth of the septum secundum, or if there's excessive reabsorption of the primum septum, because this hole forms from apoptosis and death of cells in the septum primum. But the bottom line is, if either of these things occur, then you get a hole between the left and right atrium. And the most important thing to know about these secundum type defects is that they're located in the mid-septum. I'll show you a picture of this in a minute. And they're often an isolated defect, not associated with any other congenital heart pathology. So here's a little cartoon to show you how these secundum type ASDs develop. So this is what the normal situation should be. But if the septum secundum here in red is too short, then you can have a hole here, and that's a secundum type ASD. The other way you could get it is if the septum secundum grows normally here, but the septum primum gets excessively reabsorbed. So you have a big hole here instead of a small one like you're supposed to have. Either of these two abnormalities will lead to a persistent communication between the right and left heart that is a secundum type ASD. So this is an echocardiogram image of what one of these secundum type ASDs look like. This is the right atrium over here. This is the left atrium over here. And this is the defect right here, this black space. You can see that it's located in the middle of the wall, right? We've got some wall above it and some wall below it, and we've got the defect right in the middle. That's what these secundum type ASDs look like on echocardiogram. There's another type of ASD called a primum type that is less common. This is a defect at the site of the ostium primum, not the ostium secundum like the secundum types. It's caused by failure of the primum septum to fuse with the endocardial cushions. So in the video on cardiac embryology, I talk about how in the primitive atria, this blue wall, this septum primum, grows downward and it fuses with the endocardial cushions, which are denoted in green here. Well, if it doesn't grow down and fuse, then you're going to have a hole here, which is going to allow communication between the right and left atria. And that hole, importantly, is going to be very far down, close to the mitral and tricuspid valves. It's not going to be in the middle of the chamber like the secundum type ASDs. And so I've highlighted these points here. These primum type ASDs, which are less common, are located near the AV valves, meaning near the mitral and tricuspid valves. They're not in the middle of the wall between the left and right atria. And in contrast to secundum type ASDs, these often occur together with other defects. In particular, you can see them as components of so-called endocardial cushion defects, which are seen in children with Down syndrome. And I talk about Down syndrome and these defects in detail in videos in the genetics section. And here's an echocardiogram image of a primum type ASD. Once again, this is the right atrium here. This is the left atrium here. This is the hole. And hopefully you can appreciate that it's not in the middle of the wall. It's down here, closer to the ventricles. This is the right ventricle and the left ventricle over here. And the hole is located down at the bottom of the wall. That's typical of those primum ASDs. Okay, moving on. The next shunt we'll discuss is a patent ductus arteriosus, or a PDA. So in the video on cardiac embryology, I talk about the fetal circulation, and I talk about how the ductus arteriosus in utero allows blood to move directly from the left pulmonary artery to the aorta, shown here, bypassing the lungs. Now, the ductus arteriosus should close after birth. It's said to have functional closure in 18 to 24 hours after birth, and this is because there's smooth muscle in the ductus arteriosus that constricts to shut off blood flow. And then there's so-called anatomic occlusion over the next few days and weeks, where the ductus arteriosus gets converted into connective tissue, and it will eventually become a structure called the ligamentum arteriosum. And it's high yield for you to know that in utero, what maintains the patency of the ductus arteriosus is the relatively low oxygen tension, because there's less oxygen in the fetal blood compared to blood after birth, and also high levels of prostaglandin E2. And the major source of prostaglandin E2 in utero is the placenta. So when the placenta goes away, E2 levels fall. And also after birth, oxygen levels rise when the baby begins to breathe. And those are the triggers that lead to closure of the ductus arteriosus. If the ductus arteriosus doesn't close after birth, it will then become a PDA, which is a type of shunt. And this is relatively rare. It only occurs in a few births per every 10,000 births. But besides knowing the anatomy of the ductus arteriosus, meaning where it connects from and where it connects to, there are just a handful of other high-yield things to know about this disorder. One of them is that it's classically associated with congenital rubella syndrome. We almost never see congenital rubella syndrome in the modern era, but it's one of the torches infections, which I talk about in detail in videos in the reproductive section. But if a mother who is pregnant develops the congenital rubella syndrome, her baby is more likely to be born with a PDA. So the way this will present in a board question is the mother will develop a rash, fever, and lymphadenopathy during pregnancy. That's the mother contracting rubella. And then the baby will be born with deafness, cataracts, and also cardiac disease, including PDAs, which are very common. Besides the association with congenital rubella syndrome, the other high-yield thing to know about PDAs is how to recognize one of these shunts in a board question that describes the physical exam findings in a baby. So first of all, you should be aware that PDAs cause a continuous murmur. It is present through systole and diastole. Remember that in PDAs, blood is flowing from the higher pressure aorta to the lower pressure pulmonary artery, and it's going to flow through this shunt during all parts of the cardiac cycle, diastole and systole, and that makes these shunts different from other shunts like VSDs where most of the blood flow is in systole. The murmur is classically described as machine-like, and I have an example of what it sounds like in the video on heart murmurs. Another classic finding in a person with a PDA is a widened pulse pressure. So let's explain what I mean by this. Our blood pressure normally goes up and down between two values in the cardiac cycle. We call this the systolic value of blood pressure and this the diastolic. And the difference between these two is the pulse pressure. Well, what happens in babies with a PDA is blood continues to leak out of the aorta through the PDA, and therefore the diastolic pressure gets much, much lower compared to normal. And so this leads to a low diastolic pressure, and that makes this pulse pressure much greater in value, or we call it wider. And that's a consequence of having this shunt where blood can leave the aortic system and go over to the pulmonary artery. If a PDA is left untreated and the shunt reverses and becomes right to left, like I talked about earlier when Eisenmenger syndrome develops, this classically leads to a finding called differential cyanosis. In differential cyanosis, the person with the PDA where the shunt has reversed will have blue toes indicating cyanosis, but normal appearing fingers. And the reason for this is that when the shunt reverses right to left, it's sending deoxygenated blood into the aorta after blood has already left the aorta for the arms. So the arms and the hands and the fingers are going to get oxygenated blood coming from the lungs, but the lower extremity, like the toes, is going to get mixing of oxygenated blood with deoxygenated blood from the shunt, and that's why the toes appear blue, and this is called differential cyanosis. Babies with a PDA can also have a loud S2. This is a finding you get anytime there's pulmonary hypertension. And when you have blood flowing from the aorta into the pulmonary artery, that can raise the pressure in the pulmonary artery, causing pulmonary hypertension. And then finally, anytime you have this wide pulse pressure, you're going to have a high stroke volume. And that's true in babies with a PDA. And so that leads to bounding pulses. There's just a large amount of blood being pumped. You can get the same physiology in people who have AV fistulas. They are just pumping a large amount of blood to try and fill the arterial side of the body where blood is leaking out through a shunt. And so this creates these bounding pulses that you can feel in physical exam, consequence of high stroke volume. Okay, another high-yield thing to know about PDAs is that there is a drug called aprostadil, which is prostaglandin E1, and this can be given to babies to maintain the patency of the ductus arteriosus. Now, why would you want to do this? Well, it turns out in certain forms of congenital heart disease, it's very hard for babies to get blood from the right ventricle into the pulmonary artery in the lungs. So by keeping the ductus arteriosus open, you can deliver more blood to the lungs. Remember, the ductus arteriosus allows blood to go from the aorta to the pulmonary artery, and from there it can go on to the lungs. Well, if the baby has a problem getting blood from the right ventricle into the pulmonary artery, then by keeping the PDA open, you provide another pathway for blood to get into the pulmonary artery and then to the lungs. And so this is helpful with babies who have cyanotic forms of congenital heart disease, especially tetralogy of Fallot and pulmonary atresia. I talk about both of these conditions in another video, but when babies are born with these problems, they can't get blood from the right ventricle to the pulmonary artery, and so keeping the ductus arteriosus patent with aprostadil is helpful for these babies. And then finally, the opposite of aprostadil is indomethacin. Indomethacin is an NSAID. It inhibits cyclooxygenase, and it will drop prostaglandin formation in the baby. And so this drug can be given to close a PDA. When a newborn doesn't have the ductus arteriosus closing on its own, they can receive indomethacin, and that will often lead to closure of the shunt. Let me mention a concept that you should be familiar with so you can answer board questions about all of these shunts we've been talking about. And that concept is the ratio of QP to QS. So when we say QP, we mean the pulmonary blood flow, and when we say QS, we mean the systemic blood flow. And in normal individuals with normal hearts and normal vascular systems, the QP to QS ratio should be 1:1. In other words, the amount of blood going into the lungs as pulmonary blood flow should equal the amount of blood going to the body as systemic blood flow. In the shunts we've been talking about in this video, however, the QP-QS can become greater than 1:1. It can become something like 1.5:1 or 2:1 or 3:1. And the reason this happens is because when you have one of these shunts, they allow blood to move from the higher pressure left side of the heart to the lower pressure right side of the heart. And therefore you get more blood flow on the right side of the heart going into the lungs, the pulmonary blood flow, and relatively less blood flow going to the systemic side. And so therefore these QP-QS ratios can get greater than 1:1. And if you just know this, then you'll be able to recognize this concept in a board question if they talk about the QPQS ratio. Okay, earlier in this video, I mentioned Eisenmenger syndrome, so let's talk about that now. So this is what happens when a baby's born with one of these shunts, like an ASD or a VSD or a PDA, and it goes uncorrected and the baby begins to grow. You'll rarely see this in the modern era because we have surgeries to correct these shunts. But in the 1940s and 1950s, babies who were born with one of these shunts right here would grow up and eventually the shunt would reverse and that would lead to Eisenmenger syndrome. So the way that you develop Eisenmenger syndrome is the right heart is chronically overloaded from the presence of one of these shunts. Over time, the right ventricle starts to hypertrophy, and over time, pulmonary hypertension develops. And as the baby gets older and enters childhood, the shunt reverses and starts to allow blood to flow from right to left. So now you have blood bypassing the lungs, and the child is going to become cyanotic. So they can develop blue fingertips and blue lips, that's cyanosis, low oxygen tension. Clubbing of the fingernails is a classic finding in cyanotic congenital heart disease. It also occurs in other lung conditions. It's not specific for cyanotic congenital heart disease, but it is a classic finding, and that's what's shown here, where the fingernails sort of bulge out like this. This is called clubbing. And then lastly, when these shunts reverse, these children develop polycythemia, a very high hematocrit, and that's because their body's being deprived of oxygen, so their bone marrow is responding by producing more red cells. Let me briefly mention fetal alcohol syndrome, which I talk about in more detail in videos in the psychiatry section on alcohol use disorder. But fetal alcohol syndrome occurs when babies have prenatal exposure in the womb to alcohol that the mother consumes, and that's because alcohol is a teratogen, meaning it disrupts normal development. Children born with fetal alcohol syndrome have characteristic facial features. This is a picture of what it can look like on the slide here. They also have impaired neurologic function. But for our purposes here, what you want to remember is that children born with fetal alcohol syndrome have higher rates of certain congenital heart defects. In particular, atrial septal defects and ventricular septal defects are relatively common, and also tetralogy of Fallot, which is a form of cyanotic congenital heart disease that I talk about in another video. And then I'll finish this video with one slide on patent foramen ovale, or PFOs. So in the video on cardiac embryology, I talk about how the foramen ovale develops in utero, and that allows blood to move from the right atrium to the left atrium in utero, bypassing the lungs. At the time of birth, the foramen ovale should close, but in about 25% of adults, this doesn't happen, and so they will go on to have a PFO. Usually, this is of no clinical consequence. PFOs are too small for any significant shunting, so usually they are simply something that's present in the heart, but they don't lead to any disease or other problems in life. The one exception is in very rare cases, a person can have a DVT or a pulmonary embolism, and by this I mean a blood clot in the venous system, and that blood clot can cross through the PFO to get to the left atrium, and from there it can go on to the brain to cause a stroke. So it is possible, although it's very rare, for someone to have a stroke because of a PFO, and that's because they formed a blood clot on the venous side of the body that crossed over to the left side. And this is an ultrasound image of a PFO here on the slide. This is the right atrium here. This is the left atrium. This is the PFO. Blood can move like this through this defect in the wall between the right and left atria. As I said, it's too small for any significant shunting. Really, the only risk is that if you got a clot forming over here on the right side of the body, like in the veins of the legs or somewhere like that, a piece of it could break off, and sometimes it can go through this PFO to the left atrium, and from there it can cause a stroke. And that concludes our module on shunts.